Okay. Hi, I'm Maureen Bradley. I'm the Director of Alzheimer's Care for the Royal Health Group. The Royal Health Group has memory units in Braintree, Falmouth, Fairhaven, Buzzards Bay, North Reading, and Falmouth. So the reason why you're here is because the state of Massachusetts made Alzheimer's regulations in 2014. The regulations state that anybody who works in a long-term care facility needs to do 8 hours of Alzheimer's care. Our program is 6 hours in the classroom and 2 hours on the units. It's done with video and with people speaking. So I'm going to start with our philosophy and mission statement. So the mission statement for the Royal Health Group is the skilled nursing facilities of the Royal Health Group are committed to provide a safe, nurturing environment that encourages a feeling of comfort and safety through a structured, individualized lifestyle. And our philosophy is we believe in the quality of life for a person with Alzheimer's disease is enriched when we honor the uniqueness of each resident by building on their strengths and understanding the essence of each resident. So Alzheimer's facts: 1 in every 10 families is affected by the disease process. 1 out of every 5 people over the age of 75 will have the disease. People with the disease can still live at home or in assisted living, and we'll see them after a hospital stay. Some of them will get ready to go back to their home or back to their assisted living, which is why we offer short-term rehab in our Alzheimer's units. When they first get there, they're going to be more confused. Some of these people won't even know that they have a memory problem until after the surgery. Once they're clear from the anesthesia and the narcotics, they will be back to baseline. So the person that has dementia is not necessarily the same person that they were before. We think that they were always their behaviors when in fact they weren't. Behaviors with Alzheimer's disease happen because of changes in the brain. Alzheimer's disease is a neurological disease, not a psychiatric illness. When caring for someone with Alzheimer's disease, you're caring for the whole entire family, not just the resident. The life expectancy of the disease is 2 to 20 years. That means when it first starts, we don't really notice when it first starts because they start forgetting little things, or they misspeak once in a while. So we don't even know they have the disease, so they're pretty well into it. Not all people with Alzheimer's disease not all people with dementia have Alzheimer's disease. There's multiple different types of dementia. It's like everybody with a cold has a fever, but not everybody with a fever is because of a cold. It may be some other type of infection. 75% of people who live in long-term care are going to have a diagnosis of some type of dementia. And people as young as 30 can get Alzheimer's disease. That's called younger onset Alzheimer's, which is really, really difficult for people in their 30s because they're still employed. So what is dementia? Dementia is a progressive neurological disorder that causes problems with thinking, memory, and interferes with all activities of daily living. People with dementia will have problems recognizing people and things. Normal aging versus dementia. Normal aging, we forget details of an event, or people with dementia will forget the entire event. An example of this: one of the employees for our company, her mom has Alzheimer's, and they were going to a wedding in Boston. So she went to pick up her mom, brought her to the wedding in Boston, and there was an hour delay between the wedding and the reception, so she was bringing her mother home because the reception would have been too much for her. She gets in the car with her mother, she's driving home, just leaving the wedding, and her mother says to her, "Aren't we supposed to go to a wedding today?" Now, normal people without dementia would probably forget some things that happened in the wedding, or they'd see it differently than somebody else, but they'd remember being there, they'd remember the whole wedding. People with dementia are unable to form new memories. They need to be in a special care unit with specially trained staff that will enhance the quality of life for those with dementia. Types of dementia: Alzheimer's is the most common. Then you have vascular dementia, frontotemporal dementia, alcohol-induced dementia, dementia caused by traumatic brain injury. There are more than 70 types of dementia. The major symptoms of Alzheimer's: we have trouble forming new memories, difficulty with language, difficulty with movement, which is why we see a lot of falls in our Alzheimer's units. We don't recognize things in the environment, so sometimes they'll put things into their mouths that shouldn't be. They have difficulty doing a familiar task. They have difficulty with vision. They have difficulty making and following through with plans, difficulty with judgment, and changes in mood and personality. They also withdraw from social events. And I believe the reason why they withdraw from social events is because they know they can't get it all together and they don't want to embarrass themselves. And some of it's fear. They're afraid of being caught in a situation that they won't know how to get out of. Okay, so I'm going to read you a poem about a woman who has some sort of dementia, and it's called What Do You See, Nurse? What do you see, nurse? What do you see? What are you thinking when you're looking at me? A crabby old woman, not very wise, uncertain of habit with faraway eyes, who dribbles her food and makes no reply when you say in a loud voice, I do wish you'd try, who seems not to notice the things that you do and is forever losing a stocking or shoe, who resisting and not let you do what you will with bathing and feeding the long day to fill. Is that what you're thinking? Is that what you see? Then open your eyes, nurse, you're not looking at me. I'll tell you who I am as I sit here so still, as I use at your bidding, as I eat at your will. I'm a small child of 10 with a father and mother, brothers and sisters who love one another. A young girl of 16 with wings on my feet, dreaming that soon now a lover shall meet. A bride soon at 20, my heart gives a leap, remembering the vows that I promised to keep. At 25 now, I've young of my own, who need me to guide in a secure, happy home. A woman of 30, my young now grow fast, bound to each other's with ties that should last. At 40, my young sons have grown and are gone, but my man's beside me to see I don't mourn. At 50, once more, babies play around my knee, and again we know children, my loved one and me. Dark days are upon me, my husband is dead. I look at the future and I shudder with dread. For my young are all rearing young of their own, and I think of the years and the love I have known. I'm now an old woman, nature is cruel, to just make old age look like a fool. The body it crumbles, grace and vigor depart, there is now a stone where I once had a heart. But inside this old carcass a young girl still dwells, and now and again my battered heart swells. I remember the joys, I remember the pain, and I'm loving and living life over again. I think of the years all too few, gone too fast, and accept the stark fact that nothing can last. So open your eyes, nurse, open and see. Not a crabby old woman, look closer, see me. I like this poem because I think a lot of times we think that there's nobody there, that it's just a body, and that's what she's saying. She can't respond to you, but there's somebody inside her that had a full life, who raised children, who had a husband who loved her, who raised babies and grandbabies and all the things that we all do. She wasn't born with dementia, so we need to remember that. We also need to look at, we also need to look at the fact that there are people who love her, you know, and she was somebody's mother or sister. It affects everybody, so we need to make sure that we understand that. I'm going to talk about two important pieces of the brain. The first one is the hippocampus. The hippocampus is the filing cabinet of your brain. So in this filing cabinet is all your memory. So when I just say to you, what's your hippocampus? You're going to say to me, my hippocampus is the filing cabinet of the brain. The hippocampus, while it's storing those memories, somebody with Alzheimer's disease can't make new memories, so it's closed. There's no more information going into that brain. At the same exact time, though, you're losing memories. So it's kind of like an onion. You're losing the memories on the outer layers first, and then the inner layers, so you're going back in time, which is why when you see that video that you're going to see, the gentleman, when he's asked how old he is, he says he's 33 years old. An example that I have is Claire. She was in one of our facilities, and she always came into the dining room dressed in her big fluffy robe, her hat, and her flowered cane. She walked in one day and she looked at me and she goes, I have no idea why I'm here. I said to her, Claire, what do you mean by that? She goes, I'm a teenager and look around this room, they're all old people. Why am I eating with old people? So, having to be quick on your feet when you're dealing with Alzheimer's, I said to her, you know, Claire, the reason you're eating with old people is because young people sleep in late. So most of your friends will sleep till noontime. Old people get up at early, so you'll see your friends at lunchtime. She was perfectly content with that and sat and ate her breakfast. So it holds your memory, and memory is what I just said now. And a person with dementia, it's gone. So if somebody's 33, their memories only go from the time you make memories to the age of 33, which is why a lot of people don't recognize their spouses. They might have been married for 60 years, but if I'm 33, what am I doing with this old lady? An example of that, I had a gentleman, he had younger onset, he was 62 years old. And his daughters decided to send the mother on a cruise. So the daughters stayed with Dad. Mom went on the cruise. One night, Dad's sitting there with his daughter, and he goes, you know, I don't know what to do about this problem. And she said, what is it, Dad? He goes, there's a woman who sleeps in my bed, and I have no idea who she is. I haven't done anything, but I have no idea who she is. So that's why when people come and talk to somebody with Alzheimer's or dementia, don't ask them to identify you. Just say, hi, Mom, it's Maureen. Nice to see you. Because if you ask them a lot of questions, it's going to put them in an uncomfortable place. The other part of the brain that's extremely important in Alzheimer's disease is the amygdala. The amygdala is the emotional well-being. It stays with us till late in the disease process. It picks up on the emotions of others. Even at stage 7, residents have an active amygdala that picks up on the emotions of others. If a 5-year-old is around their parents who are fighting, the 5-year-old probably will think that they're at fault. A person with dementia does the same thing. They sometimes even imagine that people are being nasty when they're not. So the amygdala, one of the things about the amygdala, when we're taking care of people with dementia, the early stage people, they're pretty easy to take care of. The mid-stage people are the ones that we're chasing around all the time, trying to get them to do the right thing, trying to get them not to get into trouble, trying to get them to sit down to eat their breakfast, whatever. The stage 7 people are your ones that are in bed. You go in and you wash them, you get them dressed, you put them in the chair, you bring them out. What I ask you to do is anytime you take care of an end-stage Alzheimer's patient, when you're leaving them, you get down, you look them in the eye, you rub their back, and you say, have a great day. And the reason for that is we do that a lot with the middle stage people because we have to, that's how we redirect. But with the stage 7s, they don't get any love touches. So if we give somebody a love touch, that's going to stay with them for the whole entire day. So I ask you to do that for them. So there's a gentleman, his name is Barry Riceberg. And Barry Riceberg has come up with a scale that he uses for people with dementia. And I admire him because what he's done is he's taken normal human development and he's put it into a form that we can understand, and that is our childhood. So he calls it functional stages in normal human development in Alzheimer's disease. Basically what it is, he has this test that he does, and I'll use the same test if I go out to screen somebody in the community to see where they are, or some family member saying to me, oh, my mom doesn't belong in an Alzheimer's unit because she doesn't have Alzheimer's, she only has dementia. I'll do the same test so I can prove to them that there is something lacking there. So he compared it to a child. I don't ever want you to compare these people or treat these people like children because they're not. They're somebody's mother. But I want you to understand why they do what they do. So at stage 3, those people are still living in the community. They might still be taking care of their home because it's familiar. He compares them to a 12-year-old child. He says at 12 years old, a child can hold a job. These people can't hold a job. Now you're probably thinking, well, they're in their 80s and they probably haven't worked in a long time. But if you get Alzheimer's when you're 30 years old, that's pretty significant. There was years ago a young man that was a professor at one of the schools in Amherst, and he had just made tenure. He had a wife, some young children, and he started messing up his lesson plans. He started not showing up for class, and so they thought he was doing drugs or alcohol, so they fired him. Now, normal people, like most of us, would not be able to do something after that, but he could because he was so intelligent. So he went, which is the next stage, stage 4, is an 8 to 12-year-old child. He says at 8 to 12 years old, a child can handle simple finances. Well, with him, he could handle finances, so he went to work in a gas station pumping gas because he couldn't get a diagnosis at that time. So then he lost that ability, and they finally diagnosed him. So stage 4, you're going to see people with stage 4 Alzheimer's living in assisted living. We have them on in some of our units, especially in Braintree with our early stage unit. We'll see some of these people. They're very high functioning, but they can't live by themselves anymore. And these are the people, stage 4 Alzheimer's are the people that people will take advantage of. They'll take money from them or things from them. QVC loves them because they order all the time from QVC, not knowing what they ordered, and they'll have all the stuff in their houses. So the next one is a stage 5. He compares that to a 5 to 7-year-old child. He says at 5 to 7 years old, a child can select proper clothing. They can't. So you'll see them in their pajamas in the morning out walking on the streets, or you'll see them in winter clothes in the summer, summer clothes in the winter. Also, when you're thinking about all this, I want you to understand that it's not just that piece of it, it's everything a 5 to 7-year-old child can do. So I have people in my support group. I do a support group for caregivers, and I do one for people with the disease process. I have people in my support group who are stage 5 and they're still driving a car. My question is, if you had a 5 to 7-year-old child, would you let them drive a car? Of course not. So these wives are still letting their husbands drive cars because they're afraid to get their licenses away from them. So then they go into a stage 6. Stage 6 is, he compares to a 5-year-old child. He says at 5 years old, a child can put their clothes on. They can dress themselves. They can't do it anymore. And the problem with when they go from a stage 5 to a stage 6, a lot of times we don't even notice it. You know, we're still expecting that they can dress themselves. An example of that, I went to screen somebody in Falmouth, and she opened the door. She lived in an apartment. Her husband and her son were taking care of her, and she was dirty. Her hair was greasy. Her clothes were dirty. And so when we were sitting talking, I said to the husband, so do you have help come in and, you know, with her showering and all that? He goes, oh no, she showers every day. Well, the assumption was that she showered every day. The actual fact was that she didn't. And so sometimes it's hard for the spouses to pick up on this. And then they become incontinent of bowel and urine. They're 3 to 4.5 years old, and then they go from a 2 to a 3-year-old, and that's when you can't control your bowels. Then at stage 7 is a 15-month-old baby. At 15 months, a child can speak 5 to 6 words. They can't. At a year old, a child can speak 1 word and walk. They can't. At 6 to 10 months old, a child can sit up. They can't. At 2 to 4 months old, a child can smile. They can't. And at 1 to 3 months old, a child can hold their head up. And they can't. That's why we use Broda chairs with supports in them, because they can't hold their heads up anymore. So what I have done in my, because we have different levels, I have broken them down into, I call them shamrocks, daffodils, and roses. Now don't laugh, because people do laugh at that all the time. I'm used to it. But the shamrocks are your highest functioning people. They want routine and schedule. They'll ask what they can do next. They're good at following direction. They can follow directions 1 step at a time. They can't be reasoned with or argued with, so don't try to. Whatever they say is right. If they look outside and they tell you it's raining outside and the sun's shining, you say, yes, I wish I brought my raincoat today. They can't adjust their pace. They have poor safety awareness, and they're equivalent in functional stages to a 5 to 7-year-old child. They need consistent routine. They want they'll be able to do some of their ADLs, but not all of their ADLs, and we need to reduce the steps and have cues for them. Activity focus, they like to do anything social. They're very social people. They're like junior high school girls. They have no patience for anybody that's less than them, so if there is somebody who's less than them, they will be rude, they'll be cruel. And they'll call them names. They travel in packs. If one person is going to do something, they're all going to go because they don't want to be left behind. And then the daffodils, they like to do things with their hands. They can only see 12 to 15 inches in front of them. Yeah, I did this. And they have no side vision. So when you put something on the table, make sure it's right in their vision, not off to the side, because they're going to take the one across them. They can see that better. They need constant cues to move up to the next step, and they're the age of a 2 to 4-year-old in normal human development. They can feed themselves with verbal cues. Some of them are going to be finger food, more so than with the utensils, but they can usually use a spoon. Oh, I just waved.
That's fine. So this will actually be perfect, because then when you start a new section, we can change the angle and it won't look.
Okay. All right. They need constant cues to move to the next step. It can take them up to 3 weeks to learn a new location. The age equivalent is 2 to 5 years old. They can feed themselves with cues. They can do the task if you show them. When you're talking to them, keep your sentences short, to the point. Use simple adaptive equipment that does not require new learning. Activity focus. They'll do things with their hands. They like to organize, match, sort, and fold. They like to take things apart and put them together. Then your roses. These are your end-stage people. They like gross motor activities. They like walking or rocking. They'll sit and rock. They like music. They don't know what to do with objects, so they'll put them in their mouths. They only pay attention to things that are right within their vision. The age equivalent is 1 to 15 months old. They're totally dependent in all ADLs, so everything that happens to them depends on the caregivers. They can do nothing for themselves. They respond to touch, music, movement, and sensory stim. So when you can put them in a room with like a fish tank, lights, they need peace and quiet at that point. So one of the things that we do in our company, it's called All About Me, and that has to do with knowing your resident, and it's all part of the person-centered care movement. So in order to have a successful interaction with another human being, you ask questions, you find out who they are, what they like, you find out things about them. And the more we know about our residents, the easier it's going to be for us to take care of them. So what do they like to be called? My mother's name was Lillian Jean Rooney. Nobody ever called her Lillian. I have no idea why my grandmother named her that, but nobody ever called her that. So she goes to your facility on a Friday afternoon at 4 o'clock. She has dementia. She's in your facility, and everybody's calling her Lillian, and she's not paying any attention to any of you. And so you're thinking, oh, this lady has an attitude, or she has behaviors, when in fact, you're calling her the wrong name. So then when you finally learn the right name, some of you call her Jean, some of you call her Lillian, still haven't gotten it all together, but you decide she needs a walker. So you give her a walker and you put her name on it, but you spell it Jeanne. My mother spells her name Jean. So she doesn't take a walker because it's somebody else's. Whose fault is that? Not my mother's. It's your fault for not doing it. You want to know what they did for work? That's a good thing to know because it can help you give them something to do rather than sit with idle hands. So if I'm a nurse, you can give me a med book, you can give me little cups and cards, and I'll sort out the meds for you. If I was an accountant, give me a ledger. I don't need a computer because back then they didn't have computers. I did everything by hand. If I was a night watchman and I'm up all night, give me a clipboard and I can check off my route. Where were they born? That's a talking point. You want to be able to have things to talk about. So I was born in Contituate, and we now have a facility in Wayland. Contituate is part of Wayland. So when I go to that building, I have a lot of stuff I can talk to the people who are living in that building. Where they went to school. It gives you another thing to talk about, where they went to high school, if they went to college. Some of these people that we're caring for only went to the 3rd grade, 8th grade. That's important to know because some of them may have trouble with reading and writing. In our Fairhaven building, a lot of our residents speak Portuguese. That's something that you want to know about them. What names of their family members. If I'm walking around and I'm looking for somebody and I say to you, can you help me find Lenny? I don't know where Lenny is. I haven't seen Lenny today. And you say, oh, your husband will be here later, and I smack you. It's because Lenny's my dog. My husband's name is Peter. What do they like to do? Maybe they like to cook. Maybe they like to sit and read a book. Things that you can get off of them that they will enjoy. What makes them happy? My grandkids make me happy. I thought one time that everybody liked kids, so I had a patient in Braintree, and she was really agitated, so I thought I'll show her my kids' pictures. So I had my phone, and I'm going through the pictures with her, and she's standing with her arms crossed like this, looking at me at the pictures, and when I was done she said, very nice, but I don't like children. So I assume that everybody likes children. What makes me sad? Had a woman at Harwich, our assisted living, and every time I went in there she would say, oh, you're so tall, are you a model? And I'd say no, and she'd say, well, I was a model, but I was a short model. Tall models got paid more. So this one time she came by me, and I thought we were just going to have the same conversation, she was going to leave. She decided to sit down. So I said to her, I know you have a son, do you have other children? And she said, yes, I had a daughter who was divorced and was cooking in her kitchen, and her first husband came to the house and shot her dead. And then I had a son who went out hiking, and they never found his body. So that would be something important to know about her. If she's crying and looking for her children, are they babies or have they died? And is she living that again? Do they travel? Another talking point. Where did they travel to? Some people have been traveled all over the world. Do they like coffee or tea? This is important because if you say, would you like coffee or tea? They might say to you, I like tea. That's called echolalia. It's repeating the last word. And that's not what they like. I hate tea. I like coffee with cream and Splenda. When I get to the nursing home, though, I think I can have sugar. So if I go to your nursing home, remember I want coffee with sugar and cream. Food I like and food I don't like. Why is that important? Because I'm not going to eat something if I don't like it, and I might not be able to tell you that, but maybe if you knew ahead of time, you could offer me something that I would like. Holidays. Not everybody celebrates holidays. Not everybody likes holidays. When I was growing up as a kid, we always had great Christmases, but my dad didn't have a good Christmas when he was a kid, so he was sad at Christmas time. He was a foster kid, so he lived with families but wasn't really part of families. Do they shower in the morning at night? I shower in the morning, and I'm a morning person. I get everywhere early because that's just me. So if you gave me a shower at night, I would be so confused because I'm not an evening person. And I'd be wondering why I'm so tired if I just took my shower. And the reason I'm so tired is because you did it the wrong way. What's my religion? I once worked in a building and it was really crazy. It was a big unit and it was really crazy in the afternoon. And one of the nurses one time said, I came in and he said, you know, I found a way to keep the ladies quiet. We had a big group of Catholic residents and he gave them all rosary beads, and they sat and said the rosary beads when they were sundowning. Pets. Not everybody likes dogs or cats. Imagine if you were in a wheelchair or jerry chair, you were end-stage Alzheimer's, and somebody came and put a dog next to you. And you couldn't say anything, but you're terrified. So it's good to know if they had pets, if they like pets. Service history. That's another hugely important thing. If I was in the service, my dad was in World War II in Korea, so he wore a hat that said he was a World War II vet. That's very important to that generation because it was a lot of pride in that. Now, coming up, we're getting Vietnam vets. They still have pride, but this country didn't treat them so well when they came back. So if you know that they're a veteran, talk to them about it. You know, I think that we should have their pictures on the wall and have a veterans wall in our building so that everybody knows who the veterans were. So what we do here is we find that out, we put in All About Me, we put it in the Codex so that everybody knows what each resident is like, and what they don't like. Hugely important. When you meet a person for the first time, you ask questions, you find out what their likes and dislikes are. So you do the same thing with our residents. They all had lives before we brought them into our facilities. So we're going to talk about ADLs. The Alzheimer's Association teaches a method that's called spend 5 to save 20. What that means is that when you go in to do care, if you get them comfortable with your being there and you get them relaxed by just having a conversation about anything, you know, about nothing. It's like a Seinfeld episode. It's all about nothing, but the conversation is huge. When I was in high school, I was a nurse's aide, and I used to work 3 to 9. And I had this one resident, and she was just so nasty. She was resistive, she was verbally abusive, and I was 16, so what do I know? No, I was 18 because I was married at that point. So I knew that she liked to cook. So when I would go in, I would talk to her about cooking. And I'd ask her pointers, and that calmed her down. So she was able to let me do her care and teach me how to make stuff. I mean, one time she told me how to make good mashed potatoes, which was great because I made horrible mashed potatoes. So you want to spend time with them, get them comfortable, get them to have a positive feeling and feel comfortable with you as a person. It's not going to take longer to do their care, but it will help you to do their care because you won't get the resistive. You know, aides will say, well, I can't do that. It takes too long. No, it doesn't. 5 minutes is not too long. So it helps us to find out about their routine first, what their routine was in their care. What time of day did they shower? Bath or shower? What kind of soap? I've used Ivory soap since I was a child. So if you brought in Dove soap and I smelled Dove soap, I'd be very resistive because I don't like the smell of perfume soaps. Do I want a male or a female caregiver? You'd think that the males would prefer to have a male caregiver. Not true. They don't want another guy seeing their junk or touching their junk. So they're usually going with a female. The women sometimes don't want men, more so the women's daughters don't want them to have men do their care. So we have to find that out. You know, maybe there's a bad history with a male or a female. If a resident says no, it means no. So if you're silly enough to say to them, would you like to take a shower now? And they say no, then you can't do it. You have to walk away and come back later. But if you went in and gave them the 5-minute, you know, positive stuff and then said, come on, let's go for a walk, and you walk me to the shower, I'll probably be more agreeable. You have to have all your equipment. I'm not good at this. I'll forget a face cloth or soap or something like that, but you have to have everything there because you can't expect them to stand there and wait for you to get back. When you do the shower, start at their feet, work your way up, have multiple face cloths, and don't pour water over their heads. They don't lug water on their heads. Let them do as much as they can. If you don't, then it's going to cause excess disability. And excess disability is taking away something that somebody can do and making them dependent on it. Watch for signs of had enough. Stop fidgeting, restless, pushing you away. You just saw the film Bathing Without a Battle, and in that film the lady was telling them she didn't want to be there, and they kept doing her over and over and over and over again. Like, all you have to do if they're agitated is their face, their armpits, and their privates, and then you're done. We need to understand the resident doesn't know what they can or not do, so they may say they can do it for themselves, or they'll say, my husband will be here later, he'll help me, my daughter's going to take care of me, I already showered. No, you didn't. One way to get things done with residents, especially if you're trying to dress them, it's called hand over hand. So you take your hands and their hands and you bring them up and you button their shirt with your hands, or you brush their hair hand over hand. That makes it, it's called muscle memory. Their muscles and their brain are going to know exactly what you're doing. So if you walk up to somebody and just rush up and start buttoning them, they're going to probably not be cooperative. But if you put your hand on their hand and you do it together, they're going to understand what it is you're trying to do, and they're going to probably cooperate more. When you get them dressed, let them choose an outfit. You know, you want to wear this or that. Make sure you praise them when you're dressing them. There was a lady the other day, I was at North Reading, and she had on a pair of skinny jeans, and she looked absolutely adorable, and everybody kept telling her how adorable she looked. She didn't pick out the outfit, but the person who did made her look really cute. So that's a thing to think about. If they're able to dress themselves, lay the clothes out in the order that they go on. So you want to make sure that the bra is on top of the shirt, not under the shirt, because they're going to dress in the order the clothes are put out there. Ask the family if they get dressed before breakfast or after breakfast. This is huge in our Alzheimer's units because we do family style dining. So I would not go out in my pajamas to eat breakfast, but other people would. My daughter would. She gets up and puts her robe on and comes out for breakfast. So you want to know which ones aren't going to get dressed and which ones are. The reason for that is if I'm out eating breakfast, I'm going to think and I wear clothes, I'm going to think that I have already had my care done. So after breakfast, I'm not going to go back to my room and get done. In one of the videos you saw the man walk into the bathroom, and Teepa says to him, you need to do a shave. And he said, I'm smooth as a baby's behind, or something like that. And the reason he says that is because he's all dressed. So he's all dressed, he thinks he's shaved. Men typically do not go back to the bathroom after lunch and shave. So we need to do things in their order, not ours. It makes life so much easier for us. The other thing too is all women put their bras on in 3 different ways. Either over their head, they hook them in the front, or they hook them in the back. So if you're a front hooker and somebody comes up to you with a white piece of cloth and holds it like this, you're going to think they're trying to strangle you. So if that's the reaction and they push you away, sit down on the bed with them and hook it in the front, and then they'll be cooperative because they'll understand what it is you're trying to do. Again, the more we know about them, the better off we're going to have time doing their care. Men, I don't know why men are like this, but most men stand to put their pants on. Women, on the other hand, will sit to put their pants on. So if you're trying to get a gentleman's pants on and he's not cooperating because you're making him sit down, you need to stand him up. And if he's too big for you, have somebody else help you, because that's his routine. Also, think about it. Some people do sock, shoe, some do sock, sock, shoe, shoe. If you can find out that routine, ask the family, because they probably all do it the same way, because that's the way they were brought up. Mouth care. Imagine someone coming at you with a stick and shoving it in your mouth. That's all I can think about. And mouth care in nursing homes is horrible. It's just horrible. And I think it's because people get resistive because you're shoving a stick in their mouth. If you took that toothbrush and you put it in their hand and you put the toothpaste on it and you took your other hand and brought it up and brushed their teeth that way, you'd get a better response and they would be more cooperative. Now, dentures are a little bit more difficult because dentures something they didn't probably have when they were in their 20s and 30s. But I had a very end-stage Alzheimer's resident, and she used to, if you brought the cup to her, put your hand in her hand, and took the teeth out of her mouth, she would be cooperative. I once was there and saw a nurse trying to shove her teeth into her mouth, and this resident was such a gentle soul, and she was getting very agitated. And I went to the nurse and I said, you know, give me your dentures. I put them in my hand, took Dippy's hand, she put them in her mouth. It was simple. And people think that when you do these extra things, it's going to take more time. It's not, because they're not resistive. Toileting, find out their pattern. I had a resident when I worked on Main Street, and she every day after lunch would say to us, I need to go upstairs. And the staff would say to her, oh no, there's no upstairs here, we're on the top floor. And then she'd be incontinent a stool. Once we figured that out, she probably had a bathroom upstairs that she used, and her routine was to move her bowels after lunch. So once we learned that and brought her to the bathroom after lunch, guess what? She wasn't incontinent of stool anymore. Give them time to move their bowels. You can't expect them to sit there with you staring at them while they're trying to move their bowels, and 10 minutes say, okay, I'm done. And then 20 minutes later, they have an accident because we didn't let them sit there long enough. It takes time for everything to move. And I don't know that I could do that with somebody sitting there staring at me. I think we need to be there because of their fall risk. We don't want them to fall. But maybe we can be a little bit more discreet about it when we're in there, because it's very uncomfortable to have somebody stare at you. One of the things that I find that, actually I just got a list of behaviors from one of my facilities, and one of the things they said was fecal smearing. First of all, it happens because if they have it on their hands, they have no idea what it is, so they'll take it and clean them on the walls. You know, that's what you do. If you don't know what it is and you don't know how to get it off, you're going to put it on the walls. So what do we do about that? We set up a toileting schedule, make sure we go in the bathroom with them. Sometimes they'll urinate or move their bowels in non-toilet areas. Men happen to pee a lot outside. You know, they can go behind a tree, they can stop on the side of the road and jump out. It's a little more difficult for women, so that's why I think men do that. You'll see them peeing in the potted plants, they'll pee in a corner, they'll pee in a trash can. All of that is continent. It's not incontinent because they're not going in their pants, but we need to figure out a way to get them to the bathroom so that we're not upset. And most of the resident rooms that have men in it have urine on the floor. It's like, it's a given. If they're constipated, they may disimpact themselves. The reason why they disimpact themselves is because they're uncomfortable and they don't know how to express that. So we need to really do a good job about monitoring their bowels. You know, we want to make sure that we keep track, so we give them milk and mag when they need it, and we don't give it to them when they don't. I'm going to go to Module 4, and that's about communication. You're going to see a video of a woman who is just making sound. She's sitting there going like this. But then at the end of that DVD, she also is leaving a room, and Teepa Snow is at the door. And the lady says to her, goodbye, have a good day, let me shut the door, bye-bye, sweetheart. Now, all that's automatic speech. It doesn't mean that it has any content. It's what you would say if somebody was leaving the room. So just because sometimes they can say words, it's kind of like when they can sing. Most of them can sing all the words to songs but can't have a conversation. So it's called automatic speech. With communication, it's not just your words or the tone of your voice, it's your body language. So if you're sitting there like this, they're going to know that you're mad at them, and they're not going to know why. And it might not even be them that you're upset with, it might be somebody else, but it's all about them, so they're going to think that you're mad at them. We want to make sure that the resident has all the tools for successful communication. My mother had hearing aids, glasses, and dentures. In order for her to have a conversation with you, you would have to have the hearing aids in, glasses on, and the dentures in. And the reason for that is the hearing aids she used to hear, but she also read lips, so her glasses were important. If she doesn't have her dentures in, she's going to talk like this and you're not going to understand what she's saying because she doesn't like people to see her without her teeth in. Common sense. We need to look them in the eye. This generation, is very, very important for people to look them in the eye. So if they're in a wheelchair and you're standing, get down to their level and look them in the eye. Some cultures, looking people in the eye is considered disrespectful. So when I worked for another company, I had to travel all the way to Lexington to do an in-service on communicating with residents. And the first thing I said was, when you have a communication with a resident, you need to look them in the eye. And somebody raised their hand and said, but in our culture, it's disrespectful. So if somebody in that building had just said to them, are you aware of the fact that you need to look people in the eye when you communicate with them, they probably would have been fine with it. And that's all I had to say to them. So make sure that everybody is aware that looking somebody in the eye is important. My husband and I have a very good friend, and my mother used to love him to death, but she used to say, you know, I can't really trust him. He never looks you in the eye when he's talking to you, so I'm sure he's up to something. So that's the generation that we're dealing with. Don't approach somebody from the back. Always try to approach them from the front, especially if they're in a wheelchair. Make sure they're aware of your presence before you start talking. I have a very low startle reflex, so if you came up behind me and started talking, I would probably jump. If you give them a choice, the answer may not be what they want. They might just give you the last word of your conversation back. They may also say no when they mean yes, and they don't understand the question. If you asked a child, especially a 2-year-old, would you like to take a shower? They're going to say no, you know, because they can. So the residents don't always know what it is you're asking them to do, but if they figure it's probably something bad if you're asking them, so don't ask them. Encourage them, persuade them, just guide them without asking them what to do. People with dementia, most of the people in our Alzheimer's units, all the people in our Alzheimer's units have invoked healthcare proxies, which means somebody else makes their medical decisions. That doesn't mean that they don't have the right to say no. They have just as much right to say no as you or I. So you have to respect that. If they have gobbled speech and they're not aware of it, so your job is to figure out what they're saying without embarrassing them, and just hope that you're saying the right thing. You want to always make them have a positive emotion. If English is their second language, they're not always going to be able to speak in their native tongue either. English doesn't, as a second language, they're going to be just as confused in their native tongue. If that was their only language, like in our Fairhaven building, I said earlier, we have people that speak Portuguese. So they speak Portuguese, maybe that's all they speak, but their children will tell you when they come to visit that they're not making any sense in Portuguese. Thankfully, in the building, we have a lot of staff that also speaks Portuguese to help us. Nonverbal communication, the residents can understand our mood and our emotional well-being just by being with us. They pick up on that. They're like sponges. They're like, Freud said the child in us, that's what they're like. So they pick up everything that goes on around them, even television shows. If you have a TV show on and it's talking about something horrible, they're going to think it's about them. So we need to be really, really careful about our moods. Nonverbal communication too for the residents. If I'm sitting there and I'm rubbing my head, just bring me some Tylenol. Don't ask me if I want Tylenol, because again, I'm going to say no. I'm just going to say no because I don't know what you want from me, and I'm not going to complain. So I might be rubbing my stomach. You know, we have to figure out what that nonverbal communication means, because they can't. It's like when we have our children can't talk, we can still figure out what it is they need. So we have to do the same thing with our residents. All right, so we're now on Module 5, Behaviors, Communication. People with dementia frequently have behavior problems. Why? They have no impulse control, they have poor communication skills, we're not paying attention to their needs, they're bored, they're trying to tell us something, they have an unmet need such as hunger, thirst, they don't feel safe, they don't feel a sense of belonging, they have low self-esteem. They don't feel that they are accomplishing anything with their lives. So knowing that, when we take people into our Alzheimer's units, we have to realize that we are accepting these behaviors. We know that they're going to be doing certain things, and we need to figure out how to redirect that. They're not doing it on purpose. Their brain is missing pieces. You saw that in the earlier videos, that they don't have the capacity anymore. So what are typical Alzheimer's behaviors? One of them is wandering with intrusive behavior. That's ambulation that's self-initiated and occurs without the involvement of the caregiver. With Alzheimer's disease, it seems without purpose. Early in the disease, there is a purpose. Later in the disease, there's none. The behavior puts them at risk for injury from other residents since they get into another resident's space. What are they trying to tell us? They're hungry, thirsty, bored, afraid. They're looking for people they can't find. Their mother, their father, their husband. They want to go home. They're hot or cold. They're overwhelmed. Imagine living with 40 or 30 or 26 other people all day, plus all of us. You'd get overwhelmed too. You know, it's not that you have any quiet time. And we're always saying to them, sit down, sit down, sit down. Their alarms are going off. It's a noisy place to live. They see staff going and they think it's time to go. If they were shift workers, then they've done their day. You know, they've worked to the end of the day. They're ready to go home, so they're going to follow us out. They shop. This is when they take things that don't belong to them. They're trying to tell us they're looking for their belongings. Give them a bag to put stuff in. Tell other families to make sure personal items are marked. Give them a box of stuff to rummage in. It could be anything. It could be clothes, anything you have for them to rummage in. Don't take something away from them. Try to swap. So if the resident has something that you need, I used to have residents in Braintree that used to like the narcotic book. So they would take it. And sometimes they'll hide stuff, so you have to really find it. What you want to do is offer them an ice cream. But when you give them the ice cream, have the spoon in one hand and the ice cream in the other. Then they'll have to put the object down to take the ice cream. And then you have the book. If you put the spoon in it and you hand it to them, they can still hang on to that book while they're taking that ice cream. So make sure that you do it with two different things. I one time had my work phone and I went to leave Braintree and I couldn't find my work phone. So I called it with my house personal phone. And it was on the unit. We could hear it ringing, but we couldn't find it. Somebody had taken my phone. It's in a pink case, so that's kind of like saying to you, come get me. So we could hear it ringing, couldn't find it. The nurse was standing near the med cot, and she said she saw a light go on in the trash. So one of the residents had taken my phone, wrapped it in a tissue, put it in a glove, and then put it in a glove box and put it in the trash. Thank God the nurse was standing there and the light was going off. Resident-to-resident aggression. People with Alzheimer's disease don't have the ability to control their emotions. This means if something upsets them, they will respond by hitting, yelling, swearing, screaming, etc. They are telling us that something in the area is upsetting them. So, what do? We want to monitor them for signs or symptoms that they're getting overstimulated, such as clenching their fist, rolling their hands into fists, rolling their eyes, speaking loudly. We want to put somebody in the hall to monitor them walking around during sundowning time. Don't sit people together who don't get along. I don't understand that. If you know that I don't get along with somebody, why would you sit me with them? Makes no sense to me. Keep the noise down. It's their house. It's not our house. We're visitors. If there's an altercation between two residents, whether it be verbal or physical, you need to treat each resident the same. So you walk up to them and say, I know, she gets on my nerves too. I understand why you did it. Don't say to them that they were wrong, that they should be punished, or it's your fault. It's not their fault. It's Alzheimer's fault. So you need to remember that. They're resistant to care. They're afraid. They're embarrassed. They don't know they need care. They always took a bath. They shower at night. They don't understand what you're trying to do. They don't want a male or a female caregiver. They think the caregiver's too young. So how can we help them? Find out their past routine. Don't ask them if they want a bath. Take 5 to save 20. Let them participate. Do with them but not for them. Hand over hand. And when they tell you to stop, you must stop. Not sleeping at night. Why? The reasons are the same that we don't sleep at night. They don't require as much sleep. They may be hungry or thirsty. They may be frightened. We may be making too much noise. They need to go to the bathroom. They're in pain. They work nights and are back in that time frame. We need to put them we put them to bed too early. We tend in nursing homes to put people to bed as soon as they finish dinner. So as soon as they finish dinner, we start putting them to bed. And we do it in the wrong order. Instead of putting the people that are in the jerry chairs and need to go to bed, we put the movers and shakers into bed. So by 11 o'clock, the movers and shakers have had enough sleep. They're up moving and shaking, and we're into them right. They don't get enough exercise. So how can we help? Don't put them to bed so early. Keep them busy during the day. Keep the noise down. If they wake up, get them up, toilet them, feed them. And if they still want to be up, let them be up. You can't force somebody to go to bed. Sundowning behavior. A behavior that occurs with people with Alzheimer's as it gets late in the day. They become restless and confused. They also become overstimulated. They're trying to get home to cook supper, get the kids, etc. The change in light is confusing, and they are telling us they need help and to feel safe and secure. So I don't think it's just people with dementia that sundown. I think everybody does. You know, when you get home from work, you've got to get dinner on the table, help with homework, get baths done, and you've worked all day, you're tired, the kids are cranky. When I was younger, there was a commercial for Calgon, and there's a woman, she's cooking dinner, the phone's ringing, the dog's barking, the baby's crying, the kids are fighting, and the pot's boiling over, and she said, "Oh, Calgon, just take me away." That's us sundowning. So they do it without the controls that we have. So what do you want to do? You want to pull all the drapes and turn all the lights on. Make it brighter inside and block them from seeing the changes outside. Do a quiet activity. This isn't the time of day when you want to do a marching band. This is probably the time of the day that you want to do something quiet, like reading a story, looking at a movie, something very quiet, soft music. Have them help you set the tables. The staff needs to be calm at the change of shift. Typically what happens is 7 to 3 is standing there waiting for 3 to 11 to come in. And they're saying, "Oh my God, I have to get the kids from the bus," and they're going on and on and on about everything. So their anxiety level's rising. And then the 3 to 11 staff comes in and they're complaining because they're short-staffed, they're this, they're that, they're late, traffic, whatever. So everybody's anxiety is rising, including the residents, because they feel what you feel. So we need to be quieter when we come on the unit. We need to be respectful of it being their home. We need to not make them pick up on our anxiety. Catastrophic behavior. This is an overreaction to a simple event. It could be laughing too hard at a joke, crying over something small, or becoming angrier than a situation calls for. It's really sort of an adult temper tantrum. They're trying to tell us that something happened they're not comfortable with. We all are emotional beings, but with dementia, those emotions are very close to the surface. How can we help? What triggers this behavior? What causes them to overreact? We want to validate their feelings. So if somebody's sitting crying, you want to not say to them, "Oh, honey, don't cry." What you want to say to them, "Is there anything I can do? Can I get you a cup of tea? Do you want to talk about it? Do you want to hold my hand?" You know, make them feel that their feelings are good. You know, that we can't just shoo them away and say, "Oh, it's not that bad." Verbal abuse. That's name calling, swearing, or using words in a hurtful manner. They do this because they have no filters, and they just say whatever pops into their head. They also forgot the words they were supposed to use in their place, and they're communicating to us that they are angry. Don't argue with them. You're not going to win. Don't tell them they can't swear because they're going to. They just did. They're going to do it again. They're just words. Change our behavior since we are the ones that upset them. Racial slurs, probably use words and forgot the more appropriate words. So when somebody uses a racial slur, please remember that it's not their fault. I always tell when I'm training that if they hurt your feelings, Maureen says she's sorry, because they can't, and if they knew what they were doing, they wouldn't be here. So protect yourself at all times. Maureen says she's sorry, and if they knew what they were doing, they wouldn't be here. You know, they're here for us to take care of. I don't like racial slurs any more than anybody else. I have 4 biracial grandkids, so it bothers me. I'll remember a time I brought at the time she was my youngest granddaughter. She was about 18 months old, and I used to do volunteer work for hospice. So I took her with me to visit this resident that I would visit. And this resident was the nastiest woman. She just, oh my goodness, she was horrible. She would just as soon tell you to go to hell as say good morning. So I'm sitting there with Mason on my lap, And the woman's looking at Mason, and she's looking at me, and she's looking at Mason. And I was so afraid she was going to say something hurtful or use a racial slur, because that, you know, that wouldn't have surprised me. But she amazed me, and she didn't. She said, "Whose baby is that?" And I said, "Oh, she's my granddaughter." And she reaches out and touches her skin, and she said, "Oh, she has such soft skin." It could have gone the other way too. You know, you don't know. So I'm not saying that it's okay. I'm just saying it's what they say. It's the word they used when they were growing up. When I was young, the nursery rhyme, "Eeny, meeny, miny, mo," it used to be catch the N-word by the toe. We used tiger. So that was a word that was used in their generation. When I was 16 working in a nursing home, it was all private pay. It was a very small nursing home. And I went in to take care of this woman one morning. And she said to me, "What's your name?" And I'm all excited because I'm a nurse's aide and I think it's cool. So I said, "Oh, Maureen." And she goes, "Maureen what?" And I said, "Rooney." That was my maiden name, Rooney. She goes, "Oh, another dumb Mick." I had no idea what a Mick was, so I had to wait till I got home to ask my mother what a Mick was. And she said it's a slang for an Irishman. So every nationality has a slang. I walk into a room and the women will be sitting there and they're going, "Oh my God, is that a boy or a girl?" Especially if I have pants on. And then somebody will say, "I've never seen a girl that tall. It can't be a girl, it must be a boy." So I'll go over and I'll say to them, "You know, I'm a girl, my name's Maureen, and I'm 6 feet tall." I know that's not the same as a racial slur, but it's what they think. They're not going to hesitate. If you walk into a unit and you're a big girl, they're going to, "Oh, look at the fat ass on that one." That's what's in their head comes out their mouths. They're probably the most honest people besides 2-year-olds that I've ever seen. So remember, they're just words. Change your behavior since we're the ones that upset them. You can't reprimand them. I've heard staff say to them, "Oh, you can't use swear words." You can't do that. They're adults and they're doing what comes naturally for them. Physical abuse, sometimes it's the only way they can protect themselves. They're telling you to get out of my space and leave me alone. So what do? Protect yourself at all times. If the resident says no, stop. If you think a resident is angry, step away. Remove the resident from stressful situations. Do not try to reason with them. It will not work. Redirect, refocus, and back off, and keep a sense of humor. We get so caught up. That's one thing I like about working with Alzheimer's people, is that I can laugh. I can spend my day laughing. It brings joy to people. Hallucinations and delusions. Hallucinations are seeing, hearing, feeling, smelling, or tasting things that are not there. Delusions are believing something that's not true. So what do? Don't argue with them. What they perceive is the truth. Ask if they want you to help. If it's not bothering them, let them be. Lady comes out and says, "There's a dog in my room. Would you like me to get it out of there?" "No, it's fine." I have a person in my support group. I have the wife and the caregiver and him and my people with the disease process. And he has imaginary dogs. And they jump up on the bed. Mary Claire can't sit down because she might sit on the dog. And he's very, very comfortable with it. I had another woman who used to walk around with her husband and her brother-in-law. They weren't there. They were imaginary. But so what? You know, so what? My daughter had imaginary friends when she was 3. She outgrew it. They're going to outgrow it too, but going back the other way. They're totally unaware of safety. They don't realize they can't stand up. And those alarms are so annoying. So they'll attempt to do things that they were able to do years ago. They may not remember they have a fractured hip, so they'll try to stand. Telling them to sit is not going to help, so find something for them to do. My grandson, when he was about 1.5 years, his sisters were 18, 16, and 14, I think. And in my house, I have a cape, so I have stairs that go up. And 3 girls were sitting in the living room on their phones or whatever, and Max kept walking in and trying to go up the stairs. And they're sitting there going, "Max, Max, 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 don't go on the stairs, don't go on the stairs, get off the stairs, Max." And finally I walked in and I said, "Oh, for God's sakes, he has stage 7 Alzheimer's. He doesn't understand what it is you're trying to do. Get up and get him off the stairs." So they did, or I did, and then we put the gate up. Sometimes they'll see a light bulb that's out and they'll try to change it. They'll climb up. I had one resident climb up on a table to try and change a light bulb. I don't know how he got that far without anybody noticing him, but he did. So we have to be in charge. We have to be the mothers here. Socially inappropriate behavior, that's if you take your teeth out and you dunk them in your coffee cup because they have something on them. You pick your nose. You urinate in a corner. You call people names. How can we help? Don't embarrass them. If they knew what they were doing, they wouldn't be here. We must remember that if they knew what they were doing in public, they would be mortified. Sexual behavior. Why? Because people are sexual beings and it stays with them. Staff, we flirt with them, we joke with them, we do all those things with them because we think that it's how we get them to behave. And the residents think they're much younger than they are, so they do flirt with us. So what do you want to do? The old care plan used to say the resident is sexually inappropriate, and the goal was that the resident would be sexually inappropriate less than 2 times a week by the next quarter. And then the interventions. The care plan now for somebody who asks sexual stuff is the resident has sexual behavior that puts them at risk for injury or embarrassment due to this behavior. And then the goal is that he will not be injured by other residents or be embarrassed by staff. So it's a whole different way. So when somebody's being sexual, I used to say to them, you know, I'm married, my husband wouldn't like that if they asked me to go to bed with them. So now they would say to me back, yeah, but your husband cheats on you, so it's okay. So now what I say to do, because in this whole culture change, person-centered care world, it's all about the residents. So what I would say to them now is, you know, I have to have this job. I have 5 children, and I am the single mom, and I need to work. I'll see you later. So you're not saying yes and no. You're just saying, you're letting them down gently, and you're walking away. And how nice is that? Resident-to-resident sexual behavior. You know, if somebody is kissing somebody, that's not sex. Somebody's holding hands, that's not sex. We all know what sex is, and that's not it. So telling them that they're married and they can't kiss another individual, they don't know they're married. They don't know that's not their spouse. They don't know any of that. If they're holding hands, so what? You know, some of these residents came from still living with their spouses. So they're used to kissing somebody, they're used to holding hands, they're used to being in the same bed with somebody. Some of them have been, you know, widowed or a widower for, you know, 30 years. So they haven't come right from that touching, kissing relationship. But the ones that have a really hard time. Really hard time. And our telling them that they're married or their spouse wouldn't like that is not going to help the situation. We just want to make sure it doesn't get carried away and that the families understand what's going on. The Supreme Court Judge, Sandra Day O'Connor, her husband had Alzheimer's disease, and he was in a nursing home, and he had a friend. And Sandra would go pick her husband up, who didn't know who she was at all, and pick up his new girlfriend and take them out for dinner or ice cream or whatever, because she understood that, you know, that he was looking for comfort, and that's all it was. Now, actual sexual behavior, you know, you have to, it doesn't happen I've only seen it twice in my career. Touching, you know, and you have to be careful with the level of cognition of the 2 people. If they're on the same level and they're holding hands and giving one another a kiss, that's nice. But if you have somebody who's a rose and somebody who's a shamrock and you see them together, you might want to, you want to step in, because that would be like a 12-year-old and a 2-year-old, and you don't want anything bad to happen. Sometimes it's 2 women. You know, I had 2 female residents who were, one had been married and had children, the other one was married and had no children. And sometimes they thought they were sisters, and they would hold hands and they'd walk around the unit and they'd stop in bathrooms, and one would stand outside the door. They were actually roommates too, and they would sleep in the same bed. And I'd be going out at 11 o'clock, and I would see people I'd hear them outside. They would be yelling outside. I could hear the yelling because they would ask them to, you know, to get out of the bed and go in their own bed. And that was so horrible, because what they thought was they were sisters, or the other one had a mentally challenged daughter and she thought that the other one was a daughter. So the relationships changed, but basically it was 2 women who liked one another, and they got along with one another. And the funny thing was, when one of them passed away, it was like that person wasn't even missed by the one that was still there, which was kind of weird. Sexually aggressive men, you ladies all know what I'm talking about. There's men out there that when they look at you, you just feel yucky. So they get to be in nursing homes too, and you'll know which ones they are. So I tell them, because we do touch and we do, you know, joke and all that. Don't joke with these men. Don't hug these men. Call them Mr., or if they were in the service, call them, you know, their rank. Keep a distance. If they can have a male caregiver, prefer a male caregiver's taking care of them. But the more you encourage these people, they may not, you know, touch you, but they may touch another resident. So you want to be very, very careful about them. Masturbation is done for comfort. If you walk into a room and a resident's masturbating, you walk out of the room and you shut the door. If they're in the hallway, then you gently try to redirect them so that they're not in the hallway. I'm not sure how you do that because I would be mortified, but you take a blanket or something and you bring them into the other room. Do you honestly think if they knew what they were doing, they would be doing that in the middle of the hall? I don't think so. Confabulation, you saw in the video, one of the residents in the assisted living made up a whole story about the cameraman. And so it happens. So it's done to fill in the blanks for things they can't remember. So if they can't find their sweater, they're going to say, you took my sweater, didn't you? I know you took my green sweater. I knew you liked that sweater. Well, you didn't take the sweater, so what you want to say is, you know, I don't have your sweater, but let's see if we can find it. If they don't know, okay. If they don't know who you are, they'll make up a story about you because they can. If they forgot they've eaten, and they'll say they have not, you know, nobody fed me, their children come in and they say, oh, my mother hasn't had lunch today. Well, yeah, she did, but she forgot. What you can do to help is say you're sorry. You can't find the sweater, don't argue with them. They misplaced it. Step into their reality. Okay, so Module 6 is about the behavior log, or a huddle sheet. Whenever there's a behavior in an Alzheimer's unit, especially if it's a big behavior, we want to be able to talk about why it happened. You know, we do understand that you all are doing the best that you can, and so sometimes when something bad happens, you need to be able to talk about it and what could we have done to prevent it. Because in our head, we understand that they have Alzheimer's, but in our heart, we know we're doing the best we can, and so sometimes it hurts. So what you want to do is, you want to track behaviors, you want to figure out what we can do to make the behavior not happen, and I'm not talking about using an antipsychotic medication. There are two tools that can be filled out. One's a huddle sheet, it's a two-sided document, and then there's just a simple document that just does who, what, when, and where. So who was involved, what was the behavior, where did it happen, and when. And I like people to look at that and say, okay, what caused this behavior, and what could we have done to prevent it? Because I think 99% of all behaviors, we're involved somehow. Maybe we didn't understand what they were asking us to do. And then what I find is the first line of defense is always going to be antipsychotics. I told you earlier, Alzheimer's disease is a neurological disorder. It's not a psychiatric illness. So you saw the videos with the big holes in the brain. There's no matter there. So if there's no matter there, what's a pill going to do? Unless you could fill it in like with, you know, silly putty or something, it's not going to work. So I think, and I do this all the time, I read nurses' notes, and the nurses' notes will say, you know, you take one person and they're on an antipsychotic, and all the behaviors are the same as when they're off the antipsychotic. So it's not really doing anything. I think it makes people feel better. I was reading nurses' notes the other day, and the pharmacy had recommended gradual dose reductions, and the nurses said that the physician said that it wasn't recommended because they were doing so well. As you progress in the disease process, your behaviors are going to go away. I have one building that I talked about at the International Alzheimer's Conference a few years ago, and they had started with 48% antipsychotics, and by the time I did the presentation, they were down to 6%, and now they're about 4% still. So it's been change in administration, change in nursing, and they still have the same philosophy. So that rather than medicate somebody, we try to figure out what we can do to prevent the behavior. And they've kept up with it all this time. And it's a big unit. It's Fairhaven. It's 48 beds. and they still, I think right now they have 5 people out of 48 on antipsychotics, and 3 of them have a long psych history, so they would be on it. You know, what about pain? Can we medicate them for pain if they're behavioral? Maybe that's going to help. You know, they say that an Alzheimer's disease, the biggest cause of behaviors is pain. So if we know that, why not prophylactically give them Tylenol? I once read a nurse's note. Man was dying. He was on hospice. He actually died 5 days later, and he woke up in the middle of the night and he was yelling. So instead of giving him something for pain, they gave him his antipsychotic, which I don't think is going to do anything for him at that point. So we need to look at their behavior, understand why they're doing the behavior, and figure out what we can do to prevent it, because they can't prevent it, we can. You know, is there something that we could have done differently? Okay, Module 7 is the family. Alzheimer's disease is called the long goodbye, making it difficult to watch someone change from being a functioning person, one that is dependent on others to survive. Families go through stages of grief as they go through the disease process. And it's the same as the stages in death: anger, fear, sadness, shame, loss, etc. My support groups, one of the biggest things that the wives and the husbands complain about is the loss of their soulmate, the loss of the person who they've been married to for 50 or 60 years. They've lost everything that they were used to. So when we talk about anger, yeah, they get angry because now all of a sudden they're not only just taking care of the stuff that they always did, they're now having to do the other person's jobs too. Angry because, you know, financially it's a burden. Angry because they lost their spouse. Angry because people tell them what to do. Oh, I know somebody with Alzheimer's, and you know, we didn't have to put them in a nursing home. Every single person is different. It's like all of us are different. Every person with Alzheimer's is a disease, but the person with the disease is different. That's what makes everybody so interesting. They're afraid of the unknown. You know, what am I going to do when I have to put them in a nursing home? How am I going to live? You know, a lot of times too, they'll keep them home too long because if there's 2 incomes, you know, 2 Social Security, 2 pension, and now all of a sudden, and that's running your household, and all of a sudden one of those is taken away because it has to go to the nursing home, how are you going to survive on that one if it took 2 before? It's not something that people, you know, want to do. They're very sad. They're embarrassed too, especially some of the older people. That's why a lot of times I use the word dementia rather than Alzheimer's, because dementia is a little bit easier to take than Alzheimer's. I'll have families say to me, my mother doesn't have Alzheimer's. She only has dementia, and that's a big difference. Doesn't matter what you call it, you know, it's still the same thing. So the family's not angry with us, they're angry with the disease process, but the only people they can take it out on is us. When somebody comes on the unit, you need to greet them. There's buildings that say, okay, if I'm walking around with a red clipboard, that means that I'm doing a tour. So you must be smiling and nice. Well, you should be smiling and nice to anybody that comes on your unit at any time. You know, I have been in a building, I'll tell you, there was a building that I went to. My boss was there, Robin, and the administrator in the building was at another building I was at. So I was on my way home and I called her and I said, I'm going to swing by and see the building because I hadn't seen it yet. And so she said yes. So she was touring Robin, my boss, and myself around. People didn't even acknowledge that we were there. They had no idea who we were. Nobody said hi. It was just horrible. I would never put my mother in that building. I've gone back many times since and it's changed. But we have to welcome people. First of all, we work for them. You know, if we don't have people in our beds, then we don't have a paycheck. You know, they cut staff, they cut hours because the PPD. So we need to make sure that we treat the visitors with respect. If the family questions are out of your scope of practice, refer them to a person who's best suited to handle it, like the nurse. Tell them to go talk to the nurse. Don't let families go home angry if you can resolve the problem. I had a woman, she had 11 children. Her husband died when her 11th one was a baby. And so they were very, very involved in mom's care. So they brought her in on a Friday, and Friday night, one set came. They all tried to come at a meal, so they'd, you know, space it out. and the mother had regular milk, and she's supposed to have skim milk. I know in the scheme of life it doesn't make that much difference, but to them it did. So they said something. The next morning, the 2 other family members were there, same thing, skim milk. I mean, whole milk. All through the weekend. I got there on Monday morning at 7:30, and I had 11 people waiting to speak to me. I couldn't even fit them in my office because I had a converted bathroom for an office. So they said to me, and it makes sense, if you can't get milk right, how do you do medication right? Now, this same resident eloped. We hadn't followed the policy. She didn't have a wander guard on. She didn't have a bracelet on. She wasn't in the elopement book. And they didn't find that as bad as her getting the wrong milk, which I don't understand. A physician let her out, thought she was a visitor. So families react to different things in different ways. Remember, each step in the Alzheimer's process is new for the families and a step closer to the end. So they're watching this person fade away. The thing about Alzheimer's is it doesn't have we can sort of track the disease process, but it's not like cancer. You know, cancer has a beginning, a middle, and an end. This is a very subtle change in people. So every time there's a difference, it makes them realize that, you know, they're going to lose their spouse or their parents soon. If a family member asks you to toilet their loved one, don't you dare say, that's not my patient. Don't you dare say she just went. First of all, my mother wouldn't have told me she had to go to the bathroom if she just went. And second of all, I don't care whose patient she is. My mother needs to go to the bathroom now. And they have that right. We're supposed to be a team, you know, when we work on an Alzheimer's unit, and it's very important that we have that sense of team. One of my buildings, the nurses will jump up. We have a patient that if she's on foot, then you can probably guide her to the bathroom. You can't get her up to go to the bathroom because she's not going to work. So whoever's there, it's tagged, you're it, takes her to the bathroom. Understand that putting a person in a nursing home makes the family feel as though they are failed and they may be angry with you. Listen to a family and anticipate their needs. My cousin, he was in his 20s and his sister was in her 30s and their mother was in a nursing home. She had bladder cancer and she was end stage. And so the nurses expected that these 2 young kids were going to know the dying process. Well, they didn't. And so my cousin said to me, you know, my mother never died before, so how do I know what I'm supposed to do? So if we don't guide families, they're not going to know what's the norm and what's not the norm because they've never been there before. And some people will say, well, you know, my father had it, but your father's not your husband, so you might have seen it in your dad, but your husband's going to be different. Understand if they come in and their mom says they haven't eaten or need to go to the bathroom, they're going to believe their mom. So don't argue with the family. Don't ever tell the family member, the resident's not your patient, your mom was just toilet or she already did eat. They're going to believe her mom. So how would you feel if everything in your life changed because of this disease called Alzheimer's? You know, and we always have to put ourselves in their shoes. You know, that's the most important thing. When and understand that their behaviors are a reflection on their behavior, on their family. When my dad had dementia, I would think that worst case scenario, of course, when he was diagnosed with it, I didn't even know he had it. And he was in Florida, I was in Massachusetts, so that kind of covers some of it. But we had the same conversations over and over again. You know, every time I'd call, I'd say, "Hi, Dad, how you doing?" He'd say, "How are the girls?" And that would be our conversation. So it's not unheard of that families don't recognize the disease process. But one of my fears was that the staff wouldn't understand. So my father, I told you earlier, he was a foster child. He was very religious. We went to church every Sunday. The Roonies marched into Mass at 7 o'clock Mass every Sunday. It could be a blizzard and the Roonies would be there, all 6 of us. I never heard my father swear. I'm sure he did with my brothers because back then, you know, dads and boys could swear together. I never saw my father in his underwear, which is a weird thing to say, except my friend Mo, her dad would always be in his underwear when you went over there. My father would be dressed with his change in his pockets and his shoes and socks on before he rescued us in a fire. I never knew my father was prejudiced until my daughter in law school started dating her husband, Jim. He is black. That's how I got biracial grandkids. So my fear was that I would one day walk into a nursing home, if my father ever went to one, and I would find my father walking down the hall, stark naked, calling this very large black woman a fat effing N-word. And I would be mortified. And I would hope that that aide would understand, even if she had just dressed my father 10 minutes ago, that she would understand that that's Alzheimer's walking down the hall and not John Rooney, my father. And that she would be kind to him and she would say, come on, John, you must be cold, let's get some clothes on. Because my father, if he knew that he was doing that, would be mortified. So families are the same way. You know, put yourself in their shoes. How would you feel? How would you feel if you walked in and you saw your mother covered with poop? You'd be angry like that. That's not my mom. Or I'll hear a lot of times from the families, oh, you know, my mother never swore. Well, let me tell you, I had a nun, and the only thing that she didn't swear, she threw the F-bomb like you wouldn't believe, but she never took the Lord's name in vain. So it's in there, you know, it's in there somewhere, and they're going to do it. And families shouldn't be made to feel bad about it. So Module 8 takes a village to raise a child. It takes a village to raise an Alzheimer's unit or to take care of people with Alzheimer's disease. Due to the nature of the unit, and even though this presentation is for all of our buildings, not just our Alzheimer's buildings, it's important that we still work as a team. And I know that, you know, some of the buildings, the staff doesn't do activities, but in the Alzheimer's units, we're expected to. I once went to a building in Alabama. It was in rural Alabama. And I kept seeing signs for boiled peanuts. I have no idea what a boiled peanut is. So a bunch of high-functioning ladies were sitting in a circle talking, and I went in and I did an activity with them. And we had a whole hour on boiled peanuts. First of all, they, you know, bless her heart, she's a northern girl. They couldn't understand me half the time because of my accent. And they were all going to bring me peanuts the next day. Of course, they weren't going to go anywhere. But that's why it takes, you know, I'm not an activity person at that point. I just decided they were sitting there doing nothing, I might as well have a group with them. So anybody can do that. When I first worked in nursing homes, we weren't even allowed to talk to the residents. We were only allowed to do their care. We couldn't ever sit on a bed and talk to them. You know, you can do that now. It's their home. So you take care of everybody. And the residents, and with consistent assignments, you're going to do that more so now, but I still want the residents to know all the staff so that they're comfortable going to the bathroom with whoever's taking them. Alzheimer's unit's a busy place, but if we take the team approach, it should move along smoothly. The residents need structure and a calm environment. We also need to be understanding of our fellow staff. If somebody's having a bad day or a resident's having a bad day with that staff member, we may need to step in and do the care. I've been known to give showers because the person's out of control, and I can, you know, not that I'm special, but I can go in and calm them down and we'll do a shower for somebody just because it works. It's not about the staff, it's about the residents. Nurses can answer call lights and should be a visible part of the team. Breaks should happen when they're supposed to happen and not at your convenience, because especially on the Alzheimer's units, breaks and lunches and all that are figured into the resident's schedule, so we need to make sure that we take our breaks when we're supposed to. Family members can be part of the team, and they're often looking for something to do when they visit. The other day I was at a building and a family member brought in donuts and cookies for snack. So they can be part of the team, and it should be encouraged that they be part of the team, because they don't know what to do when they get there. They're so unsure of the whole thing. Their mother never had Alzheimer's before. Okay, Module 10. Culture change, person-centered care, and habilitation therapy. Those are all the buzzwords for how we care for people now. And if you look at the survey, at the guidelines for surveyors, there's a lot of this person-centered care in there. So culture change, person-centered care, all mean the same. It means that we're supposed to understand that the attitude of long-term care is changing. We need to focus more on the home and nursing home and less on the institution of nursing care. So what does it mean for our residents? It means the resident will be the focus, not our schedule. It means accommodating the needs of individual residents, learning about each individual's interests, likes, dislikes. It's to be person-centered versus task-centered, which is very, very difficult for a lot of people to deal with, because they're so used to going in and doing everything in a row. We don't do everything in a row anymore because it's now about the resident. So if I go in and I'm going to do, you know, Mary Smith first and Mary Smith's asleep, I'll do her next. You know, I'll go do somebody else. I have one building that they're so task-oriented that changes in the afternoon happen in a certain order. And if somebody says they need to go to the bathroom in the middle of that, they don't get taken because they're out of order. You know, so they wet their pants, which makes absolutely no sense to me. It means that we'll focus on the resident, accommodate the needs, learn about their interest. It's to be person-centered versus task-centered. Let's find out about as much about the resident as we can so we can keep the same routine. If they stay in their normal routine, it's going to be easier for us to care for them. You know, bedtime, what time they get up, time they shower. We need to accommodate resident interest and choice. That means if I don't want to have my breakfast till 10 o'clock, I can have my breakfast at 10 o'clock. If I'm interested in watching the football game and it's on at 8 o'clock, I can sit and watch the football game if I want. I may fall asleep during it, but I'm still allowed to do it. And it's not so much allowing, it's accommodating. The people we care for are our employers, so we must follow their lead. You know, we lose sight of the fact, I think, that we are paid by the people we care for. You know, that's our job. And I think you're all wonderful for what you do, but again, you're not doing it because you're wonderful. You're also getting paid for it. And if we don't do it right, then we shouldn't be getting paid for it. What kind of words do we use? We all call them briefs. I even call my grandsons, when he was in diapers, I used to call them briefs too. We use bib versus napkin. We feed someone. I hate that, and I find myself using it too, but it's not somebody that needs to be fed. It's somebody who needs assist to eat. Elopement risk versus explorer. You know, most people who elope, it's not because they are trying to get out. They don't know they can't get out, so they're opportunists. If a door opens, they're going to walk out of it. The list goes on, but think of the words we use and how unkind they are. Right now, I have a resident in one of my buildings that kisses the women, and he's called the kissing bandit. How would you feel if that was your dad? You know, how would you feel? So, culture change and person-centered care and rehabilitation therapy, it's all treating people the way you want to be treated. It's looking at the person first and then our schedule. It's looking at resident strengths and not weaknesses, and focusing on their strengths. When I write a care plan, I always write a strength, because there's always something still there that they can do. So imagine being dropped in a foreign country, having to go to the bathroom, you don't speak the language, everyone is a new face, and it's a stress, and you can't express yourself. That's how it is every day in the world of Alzheimer's. Every day they get up, it's a new place, they need to go to the bathroom, and they don't know how to express themselves. So people are asking them things you don't understand. You don't recognize the environment as your home because it's not. Everyone is moving so fast, and you're frightened by all the noise and the commotion. That's what it's like to have Alzheimer's. And even if they've been in our facilities for a long period of time, it's still a new day every day. And they don't always understand what's going on. So the Alzheimer's Association calls their approach to care rehabilitation therapy. They say there are 5 domains: how we communicate, the environment, our approach to care, purposeful engagement to improve the resident's feeling of self-worth. It's not just busy work, it's feeling good about doing something, and seeing behavior as communication. In this new world of Alzheimer's care, our prime focus should be on the person we are caring for always. So I'm going to talk to you about family-style dining. Again, a lot of you don't do family-style, just the Alzheimer's units, but we should be doing more of person-centered care dining. And I'll go over the non-dementia units too. So this is module 11A. There's a video that's going to be shown ahead of time, and I want you to notice that the table's not set correctly and the dining scarves are being used there. We don't use dining scarves at homes, we use napkins. So family style dining is a means of food service that provides our residents with a familiar dining experience that will promote wellness and build on existing strengths. It will help to continue the feelings of being social during the day. So most people, I don't think I've ever had breakfast in bed in my whole entire life. Even in the hospital, I think I get up and sit in a chair to eat. But these people, they don't eat in their rooms, and they don't go out to dinner every night. So one of the things that I find in like some of your assisted livings, it's so fancy, the dining areas, that they don't even want to be there because they don't have the money to pay for that kind of a meal. So what we do is family style, and it's serving food in serving dishes. The goal is to enable residents to remain independent at mealtime. The goal is met through staff sharing a meal with the residents and providing verbal, visual, and physical assistance as needed. So each unit develops a team to look at the residents for least restricted diets, for seating residents by diet and texture and the residents' ability of choice. So you want to put them by cognition, diet, and with their friends. So every dining room has staff assigned to it. There's no breaks during mealtime, and the reason for that is because it's all hands on deck. And some of the buildings even do feeding programs so that all people can help with feeding, including the business office people. So we set the tables. We set the tables, we clear the tables, we serve the food. And when you set a table, you have to understand that these people that we're caring for lived through the Depression. They lived through the World War II, Korea, and so when they were growing up, there wasn't a lot of focus on social niceties. It was more on getting food on the table. My mother was one of 8, so there's 10 people in that house to feed. So it didn't matter how you did anything as long as you got something to eat, and it was like first come, first serve. If you're late, you're out. Once the wars ended and more money and the baby boomers came to be, there were 2 people that the women looked to. One was Dr. Spock for your children, and the other one was Emily Post. And Emily Post told them how to run a house and how to have etiquette. So if you set a table, you have to remember what Emily says. So the plate goes in the middle. On the left-hand side is the fork on top of the napkin. On the right-hand side is the knife and then the spoon. On the right-hand side are the drinks. Why is this important? Because if I've been sitting at a table my whole entire life and I reach across my body to pick up my fork to feed myself, and you have the knife there, I'm going to feed myself with my knife because it was in the fork place. And you're not going to convince me that it's the knife because it was in the fork place. So please, please, please set the table the right way. Don't roll your silverware up in a napkin because they don't understand that. Don't put all the silverware on the same side because they don't understand that. They'll sit there and try to figure it out, but they don't get it. So you need to make sure you set the table right. We use red plates and blue tablecloths, and the reason for that is the red plates help the food to show up better on. You can't have a white plate with all white food on it. They can't see it. So as the residents come into the dining room, you want to make sure they wash their hands. When they come to the dining room, you want to seat them in the proper seat. Now, people think that that's not important. It's very important. I have one unit that they do a really bad job with it, and it just makes it more confusing because if the food's coming up in serving bowls for each table, then you don't have the right people at the table. Then they're not going to get the right food. So you want to make sure that the people are sitting at the right spot. They have their dining slips out in front of them because you can't serve food or drinks without the dining slips in front of them. If they get into a certain routine, they'll come in automatically. Even the ones that are further along will come in automatically and sit at their seats. So please put them at the right seats. When the food trucks arrive, they'll be numbered so the staff will know what to bring. So the first container that comes out will have 3 dishes on it. It'll have meat, vegetable, and potato. I'm doing lunch. And then you bring the dishes over. You put them on the table, and then you serve or let the residents serve themselves if they want. Most won't because they're afraid they're going to drop it or whatever. So you serve the mashed potatoes to everybody first, and you say, would you like mashed potatoes? Would you like the meat? Would you like this vegetable? And if they say no, don't give it to them. They don't have to eat it. one thing that you need to understand too, if they refuse what you're giving them, you have to get off them an alternative that's regulatory. So then you can go to sandwich, because a lot of them will eat sandwiches for lunch and dinner because it makes them feel more comfortable. You want to make sure that it's served one at a time, like I said, and then you want to wait till they're done, and then you want to clear those dishes and put the desserts out. Staff can sit and eat with them, but they cannot bring their own food in. They cannot bring their own coffee in. If you're ever eating something different than the residents eating, they're going to wonder why you're eating that and I am not. You know, what's the difference? Is mine bad or is theirs good? I hate seeing people bring Dunkin' Donut coffees into the dining room. You know, that's not right. This is their home. And if they pick up your coffee and walk away with it, that happened in one of the buildings last week when I was there, shame on you. You shouldn't have left it out there. First of all, you shouldn't have had it on the floor in the first place. And second of all, you shouldn't have left it where they could get it. So some residents are going to need help with the meal. They need visual cues. That means if you're sitting there eating with them, they're going to follow your lead. Some of them are going to need physical cues. And some are going to need verbal cues. And some will need hand over hand to get started. You know, it's going to vary during the day. Some people who may not be, assist to dine at breakfast may be assist to dine at dinner. So you have to take your cues from the resident and, watch them to see what their needs are. So then at the end of the meal, you bus the dishes and you put them in the busing cart, which I think a lot of people have trouble with. Now, if you don't have family style dining and it's not an Alzheimer's unit, the challenges are going to be the residents can't not sit still to eat. They're unable to sit at a table with nothing to do waiting for food, and that's in both units. So you do pre-meal activities while they're sitting there waiting to eat. You talk about stuff, or you put music on and sing with them. You do a pre-meal activity so that they will stay there, they'll be engaged. Nobody's going to sit at a table for 15 minutes waiting for a meal to come. Some of the best places to go to eat, especially with kids, are like Cracker Barrel or Friendly's, because they have stuff on the table that you can play with while you're waiting for your food to come. I think it's Red Robin now, you have to pay, they have a thing that you have to pay to use. But either way, they know that if people are sitting there bored, they're not going to want to come back. So that's why you give them something to do. Sometimes they're easily distracted and lose interest in the meal. So when you bring the food, all the food should be taken off the tray. There should be no trays, even on your regular units. Offer choice. Sit people together that like one another. So the only difference in how you serve a meal in a non-Alzheimer's unit is that it's not family style, but you still want to sit people together that like each other, and there should be a seating plan. So one of the things that we do in our Alzheimer's units is we look at them being active. Most nursing homes is an activity in the morning and an activity in the afternoon and maybe one in the evening. For an Alzheimer's unit, the state requires that you have 8 hours of activities per day. So what that means is that they need to be busy. So Carly Helen, she's a occupational therapist, and she's very well known in the occupational therapy world, and she says life is an activity of being and doing. So what that means is everything we do is an activity. And then Rabbi Sam Siegel says we need to care as much about broken spirits as we do about broken limbs. And I think that's where the whole culture change movement is coming into. We need to look at the whole person and not the broken arm. It's more about the people's needs. So on the Alzheimer's units, the CNAs will run activities. They'll have scheduled activity times during the day. So the residents are divided into groups by cognition, ability, interest, and so there'll be a shamrock, a daffodil, and a rose group. They can intermix and mingle, and that's fine. There should be a variety of structured, non-structured, and normalized activities. So it might be just fold and close. That's a good activity. We need to make sure that we cover social, physical, creative, and cognitive, and sensory, and spiritual, past life roles, personal care, chores, and gender specific. That's why we do the All About Me, though, you know, so that we know what their interests are. Now, the thing about when you get Alzheimer's, you lose some control. So maybe you never, ever were social, and you weren't social because you could have sort of held yourself tight, but now you don't have that control anymore, so you can be social. Your kids will be surprised at how different you are. Maybe you never danced in your whole entire life, and now you're a dancing fool because you don't have that control. So programming should have a variety of structures. Anyone can lead a program, and a meaningful activity is based on the resident's identity, sense of physical well-being, emotional satisfaction, a need to be creative, a need to leave a legacy, a need to review, a chance to reminisce with your peers. So art projects, shamrocks can paint, daffodils can do coloring, and the roses can have nail care. All levels can attend music. You can attend big music or small music. I have a talk that I do, and it's Alive Inside, and it's about music and Alzheimer's and how important music is. And in this case, they take a headset with a playlist of music that they liked. And if you get to see it, you can download it from YouTube, but if you get to see it, it's so amazing because first of all, they walk in, this man is sitting like this on the table, and they put music on, and he all of a sudden wakes up, he starts singing, his eyes start, you know, opening, and everybody around him is smiling because he's so happy. And then after a few minutes, they take the headset off him and they go, so what is it about music that you like? And he says, life is love, music is love, music is soul, music is from God. I like him in it, but there's another woman in it that I like even better. And she's sitting there and she's holding this big bear, and they say to her, can you tell me about yourself? And she says, I'm too old to tell you about myself. I can't remember anything. So then they put music on, and I think it's Count Basie, I'm not sure. But they put the music on, and as she's listening to the music, she's talking about her and her sisters. When they were younger, they used to sneak out to see him, and how their mother hated the music. And she goes on, and then she goes, in 1942, at February, my son did this, and it just opens up all of this. So what they say is that music is like an awakening, and it will last for a while. But the thing with that type of music is that it needs to be individualized. It can't be group music. So if you're using it to calm somebody down, you put the headset on them. It's amazing. We had a lady at one of our buildings, and she was very agitated. I put big band on for her, and she's sitting there and she's dancing in her wheelchair. And I went over to her and I said, "You really like this music, don't you?" And she goes, "Yeah, it reminds me of my husband. We used to go to the ballroom every Saturday night to dance." You know, how nice is that? So music can either be a big group or it can be an individual music. There are books on the units to guide you in running activities, so I try to, in those books that I created, I put, what works, this activity works this way for the shamrocks, the daffodils, and the roses. So when you look at it, you can sort of figure out how I can run one group. In our units, we have more than one person doing activities, which is great, but in some of the buildings that don't have that, you need to be able to look at your people and say, okay, how can I do one big activity and have 3 different levels in it? And this helps you to do that. Residents can run a group. Residents can call bingo. We used to do bingo in Falmouth in the evenings, and one of the residents, that was his job, he would call the numbers at bingo. They can read a story. When I was working for a short time in assisted living, we had a resident that would read stories after lunch every day, and they'd fall asleep while they were sitting there. Of course they would, because their bellies were full, and he would get so angry to think that they were sleeping on him. He used to be a radio announcer, so he had a big booming voice. He was really good. Anybody can do it, but when you start a group, you want to make sure you introduce yourself, tell them what they're going to do, and then at the end of the group, thank them for coming and say, we'll do it again soon. Okay, we're going to talk about prosthetic environment, and that's a home-like environment. This can be used for either dementia units or non-dementia units. It's really what the culture change movement and habilitation is trying to get us to do. Prosthetic. is something that enhances your quality of life. It could be a leg, or if you have, wig, breast, hand, anything that helps improve your quality of life. Well, prosthetic environment is that. And what it is that it's a place that people go into knowing exactly what it is. So I encourage families to bring stuff, to bring stuff in so that the residents can touch their stuff, hold their stuff, be with their stuff, and recognize the environment. I find it very strange that most families won't do this. But think about, if you were in a nursing home, what would you miss? I'd miss my photo albums, I'd miss my kitchen, I'd miss my comforter, I'd miss my wall hangings, all those things that you hold near and dear and now gone. My aunt, she lived in a house with 2 bedrooms. Her and her sister-in-law lived together. And they had a kitchen, they had a family room, they had a living room, they had a huge yard for their dog, they had a 2-car garage where everything was lined up absolutely perfect, because that was my aunt's domain. And then she ended up having to go to assisted living. So we moved as many of her things from her house to her assisted living. This was when her sister-in-law passed away. So that she still had her stuff. She had a little table. I mean, it was just her stuff. She had her doilies on her nightstand. Everything that we could put in there, we fit in there. Then she went from there to Magansett, and she was in a very small room, and she couldn't have a lot of stuff, but we brought as much stuff as we could. We brought her own comforter, we brought her, and she was one of those people that in the fall had one comforter, and then in the spring had a different comforter, so we had to swap them out. We had pictures on the wall. We had an ink drawing in a big frame of different things in the town where she grew up. She grew up in Wayland. She actually lived in Contituate, but it had like the Wayland Town Hall, the old Wayland Library, and all these things are talking pieces. So when somebody would come into her room, actually a girl, when I was doing this training with her, said, I went into your aunt's room and I saw the Wayland thing on the wall, and I said to her, so Phyllis, are you from Wayland? And she said, actually I'm from Contituate. And the girl said, well, I'm from North Natick. She went to the same church, so they had things they could talk about, and that's what it is. My aunt also had a picture on the wall of her shaking hands with the first President Bush. And you'd say, why are you shaking? How did that happen, Phyllis? And she would say that he went to Raytheon. She was the president. She was in charge of security at the Wayland Raytheon for years and years and years. Amazing for 2 reasons. One, women didn't usually have jobs like that, and that she's shaking hands with the president. My aunt was also in the service. We had a picture of her in her uniform. So anything that we could do to make that room feel like hers made it feel so much better for her. And when she could, before she got in a wheelchair, but she would sit and she'd rearrange her stuff and touch her stuff, and that's what's so important. We also want to make sure that when they walk into a space, they know what it is. So they walk into the dining area in a facility, they know it's for dining. We also use them for activities. Both Falmouth and Fairhaven have wicker areas, and then Falmouth also has like a living room area with a TV and a fish tank in front of it, so that people can sit and gather. People want to watch the world go by. Our Fairhaven building is huge. The unit is huge. It's 48 beds, but it has a kitchen, and you go into the kitchen there and you sit there with the higher functioning people, gather there in the morning for coffee and activities. But it is a kitchen, and then when you walk out of the kitchen, there's a space that overlooks Main Street, and so you can sit there and you think it's your front porch and look out at the street. It's such a comfortable feeling. You want to have comfort. You want to have individualized activities, like a baby corner, things that they can mess with. So you want to have no overhead paging. You want to make sure that it's going to get messy. That's the thing about home. In the morning you get up, your house is nice and clean. By the time you go to bed at night, the house is a mess. So you put everything back together, and then the next morning you start all over again. And that's the normal ebb and flow for a home. And it's going to be like that. They can be asleep in a chair in the hallway if they want. They can be sleeping on the couch. In our Wayland building, every time I'm there's somebody sleeping on the, I do my work there, there's somebody sleeping on the sofa in front of me. And that's so nice that they feel so comfortable in their environment. You want to have distractions placed at exit doors. So distractions at exit doors are maybe a thing of hats, or maybe a thing of jewelry, you know, something that they'll look at beforehand rather than going out the door. You know, you want them to be able to get to the end of the hall and go right or left, and there'll be something for them to do or something for them to see, so they won't be going out the door. You also want to understand, and I think that my grandson, he's 12 now, said one time, we went to visit my mother at her assisted living, and he said to me, you know, Nana's really lucky to be here, Grammy. And I said, why? And he said, because she has friends, she goes to knitting, she plays cards with Benny. I mean, she does, he goes, and he's going on and on and on and on. And he goes, it's too bad that, you know, Pop didn't get to come here. And my father never would have, but then he said to me, and it's interesting, that this is the last place Nana's going to go before she goes to heaven. And if he could get it, I don't understand why the rest of us don't understand that this is the last place they're going to go before they go to heaven. So shouldn't it be fun? Shouldn't it be familiar? Shouldn't it be comfortable? Shouldn't they feel good about themselves? So all of these things so far are things to help their quality of life. You know, and we have a huge job to make it like that, you know, to understand. I saw on Facebook the other day some teenagers trying to use a rotary phone. You know, that would be like asking somebody with dementia to be living in a room that has one faucet for the bathroom. They have no idea how to turn that water on. But if you gave them 2 knobs, they'd be able to do it. So the more we can do to make it comfortable for them, the better off we are. Now we're going to talk about dignity and abuse. So the resident has the right to be free from verbal, sexual, physical, and mental abuse, corporal punishment, and involuntary seclusion. You're going to see a video with this, and it has different types of abuse. So I think sometimes we get so caught up in everything that we don't even notice, like if we're raising our voices. I once had a staff member who had been working at a facility for a long time, and the director of nursing walked by and heard the tone of voice and felt that she was yelling at the resident, and she fired her. You know, so how long had that been going on? So treating people in a dignified manner. First of all, it's very basic. You treat people the way you want to be treated, or you want your mother to be treated. I was talking to a nurse the other day, and I said to him how sweet he was and kind, and he always spoke to the residents, even when they were misbehaving, in a soft, calm manner. And then when he got them to do what it was, whether it be going down for lunch or, you know, going in to get to the bathroom, whatever it was, he very nicely spoke to them, and at the end, he always thanked them. And he always called them by name, and I said, you know, that's amazing to me that you're so kind. He said, you know, Maureen, I take care of my mother, and if I had to put her in a facility, I'd hope people took care of my mother the way I'm taking care of them. So it's so true. So if you don't cover residents on the way to the shower, that's a dignity issue, especially in a shower chair, because shower chairs were not designed to roll down the hall. Shower chairs were designed to transfer somebody in to them in the bathroom. And half the time the buckets are missing from the bottom, so their butt cheeks are hanging out. Lots of times because they sit on them, they move their bowels, or they urinate because it's the feeling of sitting on a toilet. Not pulling the privacy curtains during care. How would you like to be having the whole world walk by and see you naked? When I was in nursing school, this was so sad. My social studies teacher from high school was having a lumpectomy, and so she was on the table in the operating room, and her breast was exposed, and everybody walking by, while they waited for the frozen section, everybody walking by could see my social studies teacher laying on a table with her breast exposed. And I thought, how awful is that? You know, put yourself in their shoes. You can't write the resident's name on the outside of clothing. That's a dignity issue. I once had a resident whose wife always did that. And we'd tell her, we even documented it, that we told her, we still got cited for dignity. Not putting a resident's teeth in. It's a dignity issue. How do you expect me to eat or talk with no teeth? If you don't brush a resident's hair, there's nothing that drives me crazier than seeing somebody with bedhead. Probably because my bedhead is so bad in the morning. Not shaving a man. We got cited in one of our buildings for facial hair on a woman. That's a dignity issue. Mismatched clothing. If you dress somebody in stripes and plaids, you can get a dignity issue on that. If they dress themselves in stripes and plaids, that's okay. Treating residents like children. Even though I told you that the ages of the stages, you still can't treat them like children. They're still adults. You know, there are elders, although I'm catching up to them. Giving somebody a Barney doll, Cookie Monster, or something that's current for kids now. It's all right to give them a baby doll or a teddy bear since they know what they are. And actually a surveyor said something about age appropriate. The regulation used to be that it had to be age appropriate for any activity that you have, but now it's person appropriate. So I had, you know, issues with what she was saying. You know, she was saying, why do they have baby dolls? Or we use wayfinding pictures of them when they were younger because they recognize themselves as when they were younger. Not putting a clothing protector on during a meal. It amazes me, and I don't even like the clothing protector, the bib types. I like the big cloth napkins that we have in some of our buildings. Those are so much nicer and so much more normal. You know, I don't wear a bib when I eat. I have a napkin. Dirty fingernails. Not changing someone that's incontinent. Those are dignity. So abuse is the willful infliction of injury, unreasonable confinement, intimidation, punishment, resulting in physical harm, pain, or mental anguish. So verbal abuse is the use of oral, written, or gestured language that willfully includes disparaging and derogatory to the residents or the families within hearing distance, regardless of age or cognitive ability. You can't say someone's stupid. You can't say that somebody's ugly. You know, you have to watch what you say. You certainly can't swear at them. And I like that. What I like about this video is it goes a little over the top, but you'll see, you know, the different types of abuse and how it acts out. Sexual abuse. This could be humiliation, harassment, threats, punishments, deprivation. It also includes touching that's not comfortable to the resident. Sexual abuse is in that video too, but I don't. To me, the most vulnerable people in our society are our elders with dementia and our children. And to sexually abuse one at either end of the spectrum is just beyond my imagination. I can't understand it. There was a case of sexual abuse years ago. A woman, she was young, she came into the nursing home after being in an accident. She was in a vegetative state. She had been there a couple of years, and all of a sudden she gave birth. So she was raped by a staff member in the facility, and they found him because they did a DNA on everybody. But the thing is, here's this poor child being born to a mother in a coma and a dad who's a rapist. You know, and kind of beginning is that. Involuntary seclusion. You can't put somebody in their room and leave them there because they're being punished. You can put somebody in their room if they're overstimulated. I'm going to give you another example of involuntary seclusion. So I was doing this talk and a girl raised her hand and she said, is it okay to tie somebody's wheelchair to the handrail? Absolutely not. And I said, did you see that? And she said, yeah. And I said, did you report it? And she said, yeah. And guess what? Never got any further. So I had to go down, stop the class, the training, go downstairs and talk to the director of nursing and the administrator. Apparently we had this resident. He used to go, he was a janitor, that was his job. So he would go around the unit and he would shut off all the lights in the rooms because he was a janitor, that's what they did. But sometimes he would go in and he'd go into the rooms that the bathroom doors are open and shut those lights off. And he would scare the women. So I asked the staff if you could just, you know, keep it in mind when you go out of the bathroom door, shut the door and shut the light off, and then he won't go in, he'll just go to the doorway and shut the light off to the room. But they didn't do that. So instead they tied him to the chair rail. And the state came in to investigate. The two nurses that were there were suspended, but the state couldn't find because everybody sort of covered for everybody else, so it was without finding. What bothered me was that the aide had gone, I mean the housekeeper had gone to the nurses and told them, and they never did anything with it. So we'll talk about, you know, what you have to do if you see something in a few minutes. Poor caregiving can become allegations of abuse. This is the perception of the resident, family, visitor, or another staff member. So if I walk in and I see something that I don't think is right, I'm going to say something. And it is poor caregiving if I perceive it to be. So rough handling, not ensuring adequate fluid or PO intake. Have you ever seen somebody put a tray in a room and not open up the containers? Just leave it there. Not listening when a resident says no, allowing a resident to sit in urine or feces, not toileting on time, speaking to a resident in a gruff manner, not keeping track of the resident's property, using verbal or body language or touch that the resident perceives as sexual, too familiar, or unkind. Recently in Framingham at an assisted living, at the same time, 2 staff members videotaped themselves abusing residents. One was a naked Alzheimer's gentleman, and the CNA was shadowboxing with him, and the man was frightened, and as he turned to run away, the aide slapped him on the butt. The gentleman was crying, and the other one was a female staff member verbally abusing a resident and tormenting her. So the resident was crying and her nose was running and everything, and she made her wipe her face and lick it off her hands. Both got caught, thank God, because they were showing the videos to their friends. So things that people have gotten cited for: residents' smell of urine or in urine-soaked clothing. This we have to be really careful about with our wheelchairs. You know, if you smell a wheelchair that smells like urine, it means that somebody's been sitting in it with urine and we need to clean it. Residents observed in public areas not covered and staff passed them and did not adjust the clothes. You'll see this a lot of times with people who are Hoyas. Their shirts will come up on the side and their belly will be hanging out and nobody will fix it. A resident who's unable to cut up their food or open condiments and staff did not assist. A resident complained about being fed too fast. 2 residents sitting at the same table were fed their meals an hour apart. That's because a second resident would get up as soon as they finished. Another thing that happens, and I have this huge problem in one of the buildings that's using trays, doesn't do family style dining. I don't know if we're going to, but anyway, they'll bring trays. There's like 5 tables, and each table they'll bring a tray to. You have to serve the whole table before you can move on to the next. You also, if somebody at that table has to be assisted, you need to sit down right then and assist that person. You can't keep going. So you need to pay attention to that. And that's my one building where they don't follow a seating plan. Residents complained that the staff changed the channel on the TVs. A lot of times family members will set the TV to a certain channel so that, you know, at 6 o'clock mom can watch the news or whatever, and the staff will use their TV during the day. Staff entered a resident's room without knocking, but even better than that, we're all good at knocking, but we never wait to hear them say, come in, you know, so we need to do that. A resident was pushed in the wall with a table in front of them to limit mobility. That's, you know, especially if somebody's a fall risk, we do that, and we're not supposed to. That's, you know, you can get cited for that. Discussing a resident's condition in a public place, doing treatments in a public area, yelling at a resident. Staff member was pulling a resident backwards. People will do that rather than put foot pedals on, but you can't do that. And sometimes those broader chairs are tough. So if you suspect abuse, what do? First of all, you report it. And it doesn't mean that it's going to be found as abuse, like that case I told you about, they didn't find it. But if you suspect abuse, you have to report it. You're a mandated reporter. So you go to the, like she did, she went to the charge nurse and told her. My advice to you is, because we have to report within 2 hours, that you make sure that that nurse calls the director of nursing or the administrator. If you don't think they did, you can call them, because they have to report in 2 hours. So what happens when you report abuse? You go to me and you say, okay, I saw so-and-so do something. I listen to you, I take your statement, and then at that point nobody knows you reported it. And then I get the person. If it's abuse, then that person has to go home. And they'll be sent home until we find out, you know, what actually happened. If it's found that they didn't do it, then they come back and they get their pay. If they did do it, they lose their job and they don't get paid. But nobody knows that you said anything. You have rights and they have rights. So unless you go and tell your friends that, you know, what you just did, nobody's going to know. But we tend to tell our friends who tell their friends, and by the next day everybody in the building knows that it's much bigger than what actually happened. The person who gets accused, they don't know that you accused them, number one, and what happens for the investigation, they'll know about, but nobody else will know about. So it's totally confidential. You have to remember that we are the patient's advocates, and it's our job to keep them safe. Somebody in my class was telling me that she had just started working in a facility. She was a new member, and she was being oriented by a person who had been there for 20 years, I guess. And that staff member slapped the resident across the face. And the new CNA didn't dare report it because she was afraid that nobody would believe her. So she told somebody else who did report it, and both her and the person that slapped got fired, which they should have, because you have to. So we want to make sure that we treat others as we would like to be treated. We must make sure that we call an Alzheimer's resident by name, so this is respect, and not dear or honey. I have to say, I'm a dear or honey person, and I know I shouldn't, so I'm going to tell you not to, but I know it happens. So in conclusion, with working with people with dementia is a difficult plus rewarding job. We must never lose sight of the fact that prior to having dementia, these people had normal lives. They were mothers, fathers, sisters, brothers. They were presidents of the United States, nurses, doctors, truck drivers, teacher, and so many other things. The diagnosis of Alzheimer's disease will bring some challenging behavior, and we must learn how to prevent them. We cannot change the resident, but we can prevent the triggers that cause the behaviors to happen. The residents have definite pieces of the brain missing. So it's our job to make the rest of their lives as happy and as comfortable and as dignified as possible. Thank you. Done.
Perfect.